So, good evening. Welcome to all viewers for this EAU Euro webinar. This is the first part of an exciting series planned on screening for prostate cancer. This has been a very relevant subject over the past 3 decades already, but our knowledge has increased tremendously and our screening protocols have matured in such a way that organized testing is seriously being considered on a national and European level. The following hour, we will discuss the history of prostate cancer screening trials, lessons from ERSPC, PLCO, and CAP. And my co-moderator is Professor Monique Roobol, who knows this subject inside out. So please briefly introduce yourself, Monique.
Thank you, Roderick. Thank you very much. Well, it's a pleasure and an honor, obviously, to be part of this important webinar. And I sincerely hope that you all have an educational hour in front of you where you will learn a lot about prostate cancer screening, something I have been working on actually since 1991 and now chairing the ERSPC trial and working on all kinds of new initiatives within the PRAISE-U consortium, which you will hear a lot this evening. So I hope you enjoyed the evening and looking forward to your questions and discussion.
Thanks, Monique. And don't forget to see our colleagues at Erasmus MC. And our speakers for today will be Sigrid Carlsson from New York, Peter Albers from Düsseldorf, and Hein van Poppel from Leuven. And Monique will introduce them later during this hour. But let's get started quickly with an introduction on this topic by myself. I think it's important to present my conflict of interest here first, but I think none of these are relevant for today. It's important to realize that prostate cancer is the most common cancer in many countries in the world, especially South America, northern parts of America, Canada, and also, of course, Western Europe and Africa. And with declining rates of mortality due to lung cancer, prostate cancer even is the most common cause of death by cancer in men in many countries now, with Sweden here in Europe as a main example. So what's the situation in Europe? We have more than 300,000 new cases and almost 70,000 deaths due to this disease. And the number of cases is mainly focused in Scandinavia and Ireland, and death is mainly focused in Eastern Europe and Denmark, as you can see from these two maps. What is important to realize that mortality is not only the only relevant endpoint for prostate cancer. Metastasized prostate cancer is also a very relevant and unwanted endpoint for men and patients, of course. And as you can see here from data from the US, the number of metastatic cases diagnosed every year is about 1.5 times the number of deaths due to prostate cancer. So the burden of the disease is even higher than the death toll only. And if you look at prevalence, which is the number of men living with metastatic disease, then that's even higher, up to 3 times higher in the next few years. So the number of men living with, debilitating symptoms by metastasized prostate cancer is very large. And that prevalence is 45% caused by newly diagnosed metastatic prostate cancer and 55% from recurrent prostate cancer after primary treatment. And important to realize also that the prevalence of metastatic prostate cancer is almost 2 times higher in Black men in the USA. So the impact of metastatic prostate cancer is huge compared to localized prostate cancer. So when talking about endpoints, as we will hear on later during this webinar, it's important to realize what a relevant endpoint for screening of prostate cancer is. The disease has risk factors, mainly family history, race, and hereditary syndromes, but these are all non-modifiable. So there are no preventive measures to take, such as quitting smoking for lung cancer. So screening may actually be our main option to reduce the burden from prostate cancer. And of course, the whole screening theory is based on the fact that early diagnosis and early treatment of aggressive prostate cancer leads to better outcomes, either with this linear progression hypothesis or the parallel progression model, making sure that clones causing metastatic cells are cured early on during the disease stage. Of course, PSA was discovered in the end of the 80s, a simple blood test showing activity of the prostate, which may be caused by prostate cancer. And in the early screening protocols, PSA was the main threshold to use to recommend a prostate biopsy, yes or no. And when using that PSA in screening, and we'll hear on this topic, of course, later during this hour, there is a variation in the effect on prostate cancer mortality. In PLCO, there was no significant difference, while in the European ERSPC, there was a risk reduction for mortality of 20%, but that even increased to 52% when looking at specific groups. So these causes for variation are, of course, highly variable from the type of participants, prevalence, methodology, but especially the use of PSA in the control groups and the partition rates to the screening invitations. The side effect of screening is, of course, the over-medicalization, over-hospitalization, over-diagnosis of the disease, finding prostate cancer that don't need any treatment at all. So we need to master the power of PSA, which is like a, well, two-sided sword. And I think all these important trials that we will hear on have increased our knowledge in how to master that power of PSA and how to balance the harms and benefits of PSA screening. What has happened in the meanwhile, of course, is that opportunistic screening has been ongoing. Many men have their PSA checked, but we know that this leads to high overdiagnosis rates and it has little impact on prostate cancer specific mortality. So this is an unwanted situation. And I hope that in the future, organized testing may have a dual effect, also redistributing the use of resources from opportunistic testing in men who don't benefit to screening in men who actually do benefit. So there's a lot to discuss in this first webinar on screening, and I would like to give the word to Monique to present our next speaker.
Thank you, Roderick. Thank you very much. Well, it is my great pleasure and honor, obviously, to introduce to you my dear friend and longtime colleague, Professor Sigrid Carlsson from the Memorial Sloan Kettering Cancer Center in New York, who I know for a very long time through ERSPC and the Göteborg trial, obviously where you were very active, and now as an epidemiologist working closely together on prostate cancer screening. So please, Sigrid, go ahead and tell us everything about the traditional prostate cancer screening trials. The floor is yours.
Thank you, Professor Roobol. So let me share my slides. So it's a pleasure for me to talk about the traditional screening trials, and this is something that I've been thinking about for 20 years. And so I really enjoyed putting together the slides for this talk because I was going through my files and 2 decades of research together with the ERSPC and Göteborg trials, and a lot of memories from our meetings all over Europe. And we've made enormous progress over these years, and it's been wonderful to see how much has happened over the years. This is my funding and my disclosures. So really, when we started on this journey, we had 2 key questions. We really wanted to know, does PSA screening reduce prostate cancer mortality? And is early treatment of prostate cancer effective? Those were the key major questions that were unanswered at the time that we embarked on this journey. And this was our diagnostic toolbox. We had the DRE, we had the PSA test, we had the ultrasound, and we had sextant biopsy. And with that, we started the trials. So In the US, we had the PLCO trial with Professor Jerry Andriol as the PI, started in 1993, the same year as Professor Fritz Schroeder, and together with Professor Monique Roobol, who is now the PI, started the ERSPC trial with 8 European countries. And then Professor Hugosson, who was my PhD supervisor in Gothenburg, Sweden, started the Göteborg trial in 1995. And it started as an independent trial, but later on it joined the ERSPC with men in the core age group 55 to 69. And then some years later, the UK started their cluster randomized trial of PSA testing for prostate cancer CAP with Professor Richard Martin as the PI. And embedded in that trial is also the PROTECT trial, which is a treatment trial led by Freddie Hamdi. And so if you look at the key findings of these trials, well, they were similar, but also a little bit different. So the largest of all of them was the CAP trial. It's a cluster randomized design, so it's larger in size with almost 400,000 men. And the PLCO had 77,000 men, ERSPC 162, and Göteborg 20,000 men. You can also see that the age groups differed a little bit. So in PLCO and ERSPC, we started at 55, whereas in Göteborg 1 and CAP, we started at 50. In PLCO, they used PSA annually for 6 years and then DRE for 4 years. And in ERSPC, the interval was 4 years. In Göteborg, it was 2 years. And CAP was special that it only had one single PSA test. You could also see that the triggers for biopsy was different between the trials, with Göteborg trial having a lower cutoff. The first result that came out that was really answering the question, is surgery the best cure for prostate cancer? And that was answered by the Bill Axelsson's SPCG4 trial that showed that a radical prostatectomy has an advantage over watchful waiting for localized prostate cancer. So that gave us the first clue. But it took a little bit longer to get the results to answer the first question, does PSA screening reduce prostate cancer mortality? And really the first main result came out in 2009, and we in ERSPC published side by side with the PLCO in the same issue of the New England Journal of Medicine in 2009. And the results were different. So we had a yes from ERSPC and a no from PLCO. So we saw about a 21% mortality reduction, and it was statistically significant in the European trial, but not in the US trial. You can see that there was no statistically significant difference in prostate cancer mortality. So of course, as you can understand, this created a lot of controversy and debate. So a lot of press that came out after these two publications were published. And so what was the conclusion? Well, the more we thought about this, the more confused we got, because we had two well-conducted trials with discrepant results. But we had to continue to follow our trials to see what happened over time, to see if we could get more clues. And so with ERSPC, the more follow-up we had, we still consistently showed a difference in prostate cancer mortality between the two trial arms, whereas the PLCO continued to show no difference. And with extended follow-up, we saw the same effect. So still a significant difference in ERSPC. And over the years, we have now over 700 publications from the ERSPC that have looked at many different questions around screening for prostate cancer. The Göteborg trial also showed a statistically significant difference in prostate cancer mortality and a 44% relative risk reduction in the first follow-up at 14 years. And this continued with a 22 years of follow-up. So the Göteborg was also a positive trial. And the CAP trial, the UK trial that only had one PSA test, the first report from 10 years of follow-up had no difference in prostate cancer mortality, but at 15 years there was a significant effect, but it was smaller than ERSPC and Göteborg, so 8% mortality reduction. So if anything, it seems that PSA screening should be a dynamic, continuous process to be effective. So why have these results been debated in the medical community? Well, there's a lot of collateral damage. Even though we have an effect on prostate cancer mortality from the European trials, there is a lot of overdiagnosis. And that was the main problem, that many of these screen-detected cancers would not have become apparent or caused symptoms during the man's lifetime. So we had a lot of diagnosis of Gleason 6 or grade group 1, as we call them now. And even more problematically, back then there was a lot of treatment. So if you see in this graph here, this is watchful waiting, or nowadays active surveillance is also combined in this category. And you can see that there was very few men who opted for conservative management for localized low-risk disease. And that was, of course, a problem. Because if you model this out, which is what we did in the ERSPC trial, also published in the New England Journal of Medicine, together with a group at Erasmus of Evelyn Heinstick and her team, we did see that screening increases life years gained, but that is offset by a reduction in quality-adjusted life years owing to this overdiagnosis and overtreatment. So yes, there is a gain, but there is also harms. So the controversies continued, and there were different opinions on the efficacy. So we had this PLCO trial that was interpreted as a null trial, and then we had the other trials that did show a reduction in mortality. We also had some criticisms across the trials. There was a high degree of dilution and contamination in PLCOs, a lot of PSA tests, and also low compliance rate with biopsy in the PLCO. In ERSPC, as mentioned, there was 8 European countries, and of course there was some heterogeneity between the countries. Göteborg also had high rate of opportunistic testing in the later years and variable adherence, and the same with the CAP trial. And most importantly, and this is really what explains why the PLCO trial did not show a difference in prostate cancer mortality statistically, is because there was a lot of PSA testing in the control group of PLCO, more than 80% of men. So therefore, it was difficult statistically to show a difference. But then we had a group of statisticians take a new look at the data and looked at both ERSPC and PLCO. And if you account for differences in implementations and settings, both trials provide compatible evidence that screening reduces prostate cancer mortality by about 30% after 11 years of follow-up. And this was work led by Alex Sorikov and his team at University of Michigan. What also was debated was the numbers needed to screen and diagnose, because they were very high in the first follow-up reports. And so some felt that it wasn't justifiable from a population perspective to have screening, because if you had 1,410 men needed to be screened and 48 to be diagnosed or treated to prevent 1 death from prostate cancer, it was very high. But the longer the follow-up, the better these numbers become. So at 25 years of follow-up, those numbers are now down to 385 and 11. And this is comparable to, for example, breast cancer screening and colorectal cancer screening. And in the US, the debate, it was kind of like a swinging pendulum. So first we had the PSA test was introduced in the US, and it was very ubiquitous. And of course, there was a sharp increase in the incidence. But then the USPSTS, which is the major guideline group for primary care physicians in the US, they first stopped screening for older men, and then the conflicting trial results came out, and then they suggested to abandon screening and screen none. And then in 2018, they changed to shared decision-making, and so to screen some. So that has changed over the years. And most important was the recommendation in 2012 to really stop screening. And that was because they felt that the harms did not outweigh the benefits. And there was a lot of debate at the time, and Professor Schroeder wrote a commentary on this decision that it should be made on an individual basis, and he was a pioneer already then and talked about risk stratification already at the time, which was not mentioned. The AUA responded that the appropriate use of PSA does indeed reduce deaths from prostate cancer, and that there's a great disservice if we discourage the use of the test. And some others also recommended that this should be a grade C recommendation instead of a grade D, supporting the individual service. And that is what later changed in 2018. And many people were worried that the stop of PSA testing would lead to local growth and metastases and spinal cord compression as the first presentation, which is what we used to see before we had the PSA test. And we did show in the ERSPC trial that screening also reduces the risk of developing metastatic disease. And so that was actually what happened. So in the US, we now see a definitive and sustained increase in metastases after the guideline changes against a PSA. And even more concerning is that the death rate has leveled off in the wake of the recommendations against PSA screening. So with that historical background and what happened in the aftermath, what is then the final verdict? Well, in my view, we should not throw the baby out with the bathwater. The PSA is a very good test, and it's also an exceptionally strong prognostic marker of future risk of lethal disease. This is data from the Malmö study, where we have shown that a baseline PSA in midlife is really strongly predictive of lethal disease, an area under the curve of 90%. So it's a really powerful marker for stratifying risk. And there's also now a climate for targeted or risk stratified screening, and you will hear more about this in this webinar, mainly including the PRAISE-U consortium that is led by Professor van Poppel and Professor Roobol. We also have more modern day screening trials, the Göteborg 2 trial, which now includes MRI and compares targeted versus systematic biopsy. And that has shown to reduce overdiagnosis. So a lot of the problems we had in the traditional trial are now mitigated with MRI and targeted biopsy. And the same, if you continue to rescreen these men, you don't miss significant cancers, but you continue to reduce overdiagnosis. You can also add in risk stratification, including other biomarkers such as the 4K score before MRI, and then you can also reduce the number of men who go on to biopsy, and then while keeping the detection of significant disease. And if you look at the modern day trials that have come after the traditional trials, you can see that they are all based on risk stratification, and most include MRI. So it's a really exciting field that we are in right now. Thank you very much.
Thank you, Sigrid. This was highly informative, and I think that all the listeners do agree with me. To keep things going, we would like to continue with the next presentations and do the discussion at the end of this seminar. So without further ado, I would like to introduce Professor Albers. Professor Albers is a urologist working in Düsseldorf and at the DKFZ in Heidelberg. He is the PI of the PRO-based trial, which investigates screening in men of the age of 45 and 50. And he will talk this evening about the definition of clinically significant prostate cancer and what are the relevant endpoints of a prostate cancer screening intervention. So, Professor Albers, please go ahead and present your talk. Thank you.
So the discussion on what endpoint is really needed, that is really a tough discussion, and it is a viewpoint of different sides, from health politicians or from patients. And I would like to sum up the newest findings and ideas about this. At some point, it's a little bit theoretical, but I think you need to know why prostate cancer screening is so under debate. I have actually no conflicts regarding this talk. And I would like to start to show you that prostate cancer is really like a tsunami in the next 20 years, and not only in terms of incidence, but also in mortality. So something has to be done. And this very nice paper that was published last year had screening as one of the opportunities to tackle this danger and to get control over all this. But what about the health politicians? And not only health politicians want actually a healthy life of people, they want a reduction of burden of this disease, that is all clear. And it is also clear that early detection of diseases in general is good if you can treat them. Then you have to weigh this against cost of these measures to achieve all this. And all this plays a role in the acceptance of a screening program. The principles you should not forget: screening in cancer and other diseases is only possible if early detection really works. And this is what we come later to. Second, the disease has to have a certain magnitude and has to affect many people and has to be life-threatening. And if you detect it early, the disease has to be effectively being treated in order to gain some results. And then the reduction of costs for the society have to be proven by introducing such a screening program. If you run through all these points in prostate cancer screening, most of them are really highly detectable. So early detection is possible. It's a life-threatening disease, at least in some men. and effective treatment, if treated early, is possible in prostate cancer. And by then, it will reduce the cost for the society. Well, this is the general introduction on why screening should work in prostate cancer. But there are 2 points where it may not work. And this is if screening detects only, and this is shown in this diagram, if screening detects a cancer very early, but it's so aggressive that you cannot do anything about it and people will die. The other possibility where it does not work is that you detect it early, but you don't have to detect it because the disease doesn't kill you. And these 2 arguments have to be discussed. And I think in prostate cancer, we are dealing with the second one. So if we detect prostate cancer that is not aggressive enough to kill people, then screening doesn't make sense. That is in easy words, and I'm not an epidemiologist like most of my colleagues here. I think in easy words, it's completely understandable. We need to detect prostate cancer that are aggressive. And now we have to define what really is clinically significant. In my view, clinically significant is only this disease that leads to metastasis and finally to prostate cancer-related death. All other forms of prostate cancer and early forms are not clinically significant. And if you go through all the trials, and Professor Carlsson has mentioned major trials in the last years published, they have been published with the endpoint of clinically significant cancer defined by ISO grade group 2, that is the former Gleason 7 and higher. This is in debate because we have to prove that grade group 2 cancers kill people before we try to detect them early. Let's run through the data. The detection rate of high-grade cancers across the currently running and some of the closed screening trials increases with age. So the younger you start, the less detection rate you have for ISO 2 and higher grade. If you start screening at older age, you certainly will detect more aggressive cancers, but this may then even be too late. So currently it is really in question when to start the screening. The last trial PROGRESS tries to find out because it randomizes 45 years old against 50 years. The OPT program that you can see in the last but one row is a Swedish program starting at 50. So many of us discussing starting at that point where you don't have too many significant cancers that will be detected by screening and you can cure them. The question is ISO 2 really significant? I would again run through the just lately published trials. This is just 3 years ago, the Stockholm 3 MRI trial. It is a classical screening trial and was actually powered mainly to detect ISO 2 cancers and to try to not over-detect cancers that are ISO 1. That worked. You can see here Gleason 7A and Gleason 7B were detected in more or less the same range in 2 different ways, so classical and MRI driven. And the biopsy procedures were reduced if you introduce MRI. But is this really the important endpoint of a screening trial? Same was tested in the Göteborg 2 trial. MRI impressively reduced the detection of ISO 1 and remained the same detection of ISO 2 and higher. But as you could see in all the data, the absolute numbers of significant cancers detected is low. And the question still remains, is ISO 2 the best way to go? This is a trial that differs from the first 2 because Ansi Auvinen is leading the ProScreen trial. And this trial has an oncological endpoint. It was published with interim results last year, again, more or less copying the publication of Göteborg and Stockholm, referring to the detection of ISO grade group 2 against ISO 1 cancers. And that worked obviously by reducing the biopsies and focusing the biopsy on those that may have more significant cancers. But this trial will report oncological ideas and oncological outcomes. I think we have to go back and copy and have a look at those data that have investigated ISO 2 patients without any treatment. The reason to publish this is active surveillance that was published in Priors, driven by the Rotterdam group more than 10 years ago already. And here you can see that intermediate group patient, this is the Gleason 7, they had a treatment-free survival of already 50% after 5 years. So yourself can ask, is this really significant if half of the patients do not treatment for at least 5 years? And these are consistent findings. You have ISOP2 treatment-free survival in the UCSF trial. If you cut out the intermediate group, the same is true from the Memorial series published by Professor Carlsson, who is here on the EuroWeb. And so you see this 50% treatment-free survival that continues over more than 5 years gives an indication that ISOP2 is not really a very good endpoint. Second is, you don't have to forget, the more precisely you target the biopsies, the more you're going to find significant cancers defined at ISOP2. And then we have performed and published an investigation of one of a smaller randomized trial in Germany where we compared reference pathology. 20% of those ISOP1, ISOP2 findings are not correct. So pathologists tend to overestimate Gleason pattern 4. And this leads all to a stage shifting. So ISOP2 is actually something that will be detected and has been detected in the last years much more often than ISOP1. But this doesn't make this cancer more aggressive. It is just a matter of definition. And if you run through all this data, the first conclusion is detection of ISOP2 prostate cancer in a screening trial is not a valid endpoint and will not convince politicians to put money into that. So now let's discuss other endpoints. There is one endpoint, metastasis-free survival. I think this is attractive because when you get metastasis, systemic treatment needs to be induced. And biochemical recurrence may be a surrogate parameter for this. If you go through all this, you can see that biochemical recurrence, again, is dependent on ISO grade groups. And 20% of Gleason pattern 4 cells will still have 80% without any biochemical recurrence after 5 years. So this hints to the same fact that this is not an aggressive disease and will not instantly kill people. And if you go to very old data, this is 25 years, we have this knowledge since a quarter of a century. A biochemical recurrence of prostate cancer doesn't kill patients. So this is from Pound, a publication from Johns Hopkins to that time. Out of the 315 with biochemical recurrence that were untreated, 103 were observed for more than 8 years until they developed metastasis. So this shows that biochemical recurrence is not a very good surrogate parameter for metastasis. You have to wait too long time. Late-stage disease, this is suggested for some cancers like breast, lung. Is it better to detect late-stage disease instead of mortality? And there was a very nice paper in JAMA Oncology that was published last year, that the shift or detection to detect stage 3 and 4 cancer instead of mortality as an endpoint would make screening trials more practical because you don't have to wait so long. This is true for some cancers. I've shown you on the left side lung cancer, for example, where you have a good correlation between stage 3, that means metastasized cancer, and mortality. But now you look at prostate, there's no correlation at all. So to detect a stage 3 prostate cancer with lymph node mets or a stage 4 cancer with distant mets doesn't actually solve the problem, because these cancers are still very good to be treated and will not instantly lead to death. This is not true for lung, for pancreas cancer, or for other very aggressive cancers, but prostate is not a really good cancer in this analysis to switch from mortality to metastasis as an endpoint, or stage 3 or stage 4. Now you would think, well, overall survival is the best endpoint because overall survival will convince politicians. If people do not die because you screen, that would be the ideal endpoint. But mathematically, this is not possible. cancer screening has never been shown to save lives in most of the cancers that have been screened for. And that is very easy to explain, because even if cancer is a very dangerous disease, it only kills 3 or 4%, or is responsible for 3 or 4% of deaths per cancer. So if you have a 20% reduction in cancer-specific survival, like in, for example, the ERSPC study, this would translate in only a very small reduction in overall survival in the whole population. The only trial, or the only cancer that was proven to show a difference in overall survival, was lung cancer screening, or if you combine many screenings for cancer, like in the PLCO, prostate, lung, and ovarian cancer with colorectal together, then you may reach some influence on overall survival. But in a whole, you can see this in colorectal cancer here, for example, you would need so many patients or participants, sorry, per arm. This is 1.2 million and 13 years follow-up to show such a small effect on overall survival. So this is definitely also not an endpoint that is very feasible. So most screening trials cannot show difference in overall survival. They have to be underpowered. It's not possible to run such trials. And then you have to add the downside effect of the screening methods. If you save some lives, like it is possible, for example, here I took the latest data from the ERSPC, you have a difference in 73 deaths. And then you have to subtract the deaths that are related to the screening method. So you have many biopsies, some of them will kill patients, and you have overtreatment of cancers that do not need to be treated, and then you have radical prostatectomy related deaths that you have to subtract. So in those trials, then you end up to have 56 and 7 theoretically instead of 73 deaths avoided. So you see, screening is a problem because you have to take so many things into account in order to really have a good argument against the politicians that have to give money for this. Finally, in summarizing, I think symptomatic metastasis is something that changes the life of people, that changes also quality of life. And this takes time, as you can see in this slide. It's not only quality of life, it's also costs. You have local treatment that is very easy, but if you get systemic treatment in 2025, that is nearly up to 150,000 euros per year. And you are living several years with this enormous cost. So symptomatic metastasis and treatment of those, this may pay off. If you see the treatment costs for whole Europe, the burden of cancer, it's about 335,000 new cases per year. And then you have to just multiply this with a number you need to really treat those. There's enormous money if you have a screening program that reduces the symptomatic metastasis. And I think this is an argument politicians understand. I again took the data from the latest ERSPC analysis. So finally, smart screening, as already alluded to, the combination of risk factors. In the German trial, this is only the age. In the Finnish trial, it's age and the biomarker. And the endpoint, and these are the only two trials that are really powered to gain metastasis-free survival and to give the results on this. This probably is able to show that screening is worthwhile. All the other trials have to be critically seen and regarding to the endpoints to detect ISO2 cancers, just to detect a PRS score. This is all nice, but you have to prove the politicians that you have an effect on at least metastatic-free survival. So the reduction of cancer-specific mortality still remains the gold endpoint for screening trials. And we perhaps can discuss that metastasis-free survival may be a surrogate for this because you need a lot of money to treat metastatic patients. I think this is the main endpoint of this talk, and this consideration of endpoints, you have to really know before you start talking to politicians. Thank you, and I'm happy to take questions after then the last talk.
Thank you, Peter. This is really some food for our thoughts, and I think also for discussion. And obviously we will follow all trials with great interest, and especially those that show that use these endpoints you just mentioned. And to continue our webinar, which is already, I think, of great interest now, and I hope you learn a lot from just listening to these excellent talks. And the last one is certainly not the least one, Professor Hein van Poppel. He is a renowned urologist from the University in Leuven. He is an expert in radical prostatectomies, but has changed over time towards prostate cancer screening. And I'm very happy that he can join us. He is also the chair of the EAU Policy Office. And I work closely with him for many years in Brussels and also now for PraisU. And he's going to summarize lessons learned and how to move forward. Hein, the floor is yours. Please go ahead.
Thank you, Monique, and good evening, everybody. Thank you for the kind introduction. And indeed, I want to give a little bit an overview on what actually the EAU Policy Office has been trying to do in this history of PSA and prostate cancer screening. I hope you can see my slides. I just come back on what has been shown by the previous speakers. You know that in 1980, before PSA and before screening was there, 1 out of 3 up to 1 out of 2 men diagnosed with prostate cancer were diagnosed too late and died from it. In 1984, we got PSA, and you immediately see what was the consequence, that we found many more cancers than before, and that peaked here, as you can see. When I was just a young urologist, we just had digital rectal examination because PSA was at the start not used for screening, but just for follow-up of prostate cancer. And then, as being said by Sigrid, we had the PLCO and the ERSPC screening trials in 1993 that published controversial results, as was very clearly shown. But as been shown equally in 2016, there was a Sodikov publication summarizing, showing that prostate cancer screening decreases prostate cancer mortality indeed. Now, if you look at these graphs, so this is between 2005 and 2009, so 10 years after PSA came around, you see that the decrease in mortality by prostate cancer has been really significant, as compared, for instance, to bladder and kidney that are here below. So since the introduction of PSA, no other cancer did actually better than prostate cancer, but at the cost of overdiagnosis and overtreatment. And you see that in the PLCO trial, this was about 20%. And in the ERSPC, it was about 50% of cancers detected should better not have been detected at all. And the consequence was that because of this overdiagnosis and overtreatment, the United States Preventive Services Task Force gave a recommendation against prostate cancer screening. It was said at that time that it's not a killing disease, it's an indolent old man's disease. You will die with and not from prostate cancer. The treatment can lead to unpleasant side effects, and certainly it leads to overdiagnosis when using the old parameters of a PSA above a certain value that immediately led to a biopsy. And obviously overtreatment was the consequence, with the harms outweighing the benefits. I must say that we were indeed not able to distinguish, to discriminate between significant and insignificant cancers. And in my own practice, I certainly inflicted radical prostatectomies on maybe 15 to 20% in my initial experience to men that did not deserve a radical prostatectomy because their tumor was too low grade. But the anti-PSA propaganda has started after the United States discouragement of it. And this was the consequence. And you see immediately after a couple of years, man detected with metastatic disease has increased. So prostate cancer was more and more detected too late. And you have seen this slide from Sigrid earlier. This is the blue line, is prostate cancer. The mortality has come down for years, but this decrease has leveled off And there has been an increase in the end of prostate cancer mortality. You see what happened, for instance, for lung cancer in the red line. What happened in Europe? When 92,000 men died from prostate cancer in 2010, 107,000 died in 2018. And we have better diagnosis and we have better treatment. So there's something wrong. And you have seen this slide before, and you see that in Eastern Europe, for instance, there's going to be a tremendous increase in prostate cancer incidence, but also an increase in mortality. That we need to do something about this is absolutely clear. Now, is there a rationale to do? Screening in the EU is the first incident and second or third male killing cancer. In Sweden is the number one, as has been said, simply because there's less smoking and less lung cancer mortality. Screening decreases prostate cancer mortality. There's no debate about this any longer. We need to stop the increasing too late diagnosis and the opportunistic screening that is widely ongoing in the European Union and elsewhere is costly and it is inefficient. And finally, we know that late stage is terrible as it comes to quality of life, and the treatment, as Peter Albers has shown, is very expensive. You see that in this man, over 18 years, for the local treatment of this tumor that was detected too late, you see your expense is 10 to 15,000 euros. But medical castration already is 11,000 euros. And with all the new drugs, and certainly with lutetium around the corner, you spend 240,000 euros just to extend a not very qualitative life for 2 to 4 years. So what did we do? Instead of continuing to talk with urologists and with oncologists, we needed to make the policymakers aware of the problem. And when I got retired, I must say that I introduced EAU within the political circles in Brussels. And we had a very nice opportunity when Ursula von der Leyen presented the Beating Cancer Plan. We're going to beat cancer in Europe. And I was sitting on the first row here, and I took this picture, and we said, yeah, you cannot mean it. You cannot be serious if you do not do something about the first incident and the second killing cancer in Europe. Oh, okay. But then you need to prepare a novel way of early detection that avoids overdiagnosis and overtreatment, and that stops the ongoing expensive and ineffective opportunistic screening. And this is where we started to write recommendations for the EU cancer plan to tackle prostate cancer in the European Union. And it's obviously, it's the saint, it's the Pope of prostate cancer screening in Europe, Monique Roobol, who really made clear that we should not have a PSA of a certain value leading to a biopsy, but that we need risk stratification in between. MRI, and finally we have come up with a proposal to the European Commission that we have PSA, risk stratification to see whether the patient needs an MRI, risk stratification after the MRI, and only then a biopsy. And you have heard that we can, within next to MRI, also include neurobiomarkers. But the advice to the European Commission for all European Union countries, this would be far too expensive to include in population-based programs. And then we have written, and you see the authors here is Peter Albers and Roderick and Monique Roobol, next to Jelle Barends and René Hogenhout, who has actually produced the paper, not for urologists, it was in European urology, but for the European Union and the European Commission, to say that we propose a population-based, organized, PSA-initiated, risk-stratified screening by invitation, information letter to all healthy, unsuspicious men between 50 and 69. And we've been to the parliament again with Holy Monique, with Michel Battier, with Chris Chappell, with the chairman, Nicolas Mottet of the guidelines office at that time. We wrote a number of white papers in 2017, 19, and 20 to emphasize that the solution is not to do organized screening and not new randomized trials, to show that MRI works, that 4K works. These things are ongoing. There's multiple trials ongoing still, but we need to do an organized screening program. And what does it mean? What is organized? It's done by an organization, by an institute, with a letter of invitation and information to all men, non-suspicious men of a given age between 50 and 70. We need to keep these healthy men out of the medical care system. Do not make them patients. This is healthy people. It's the system, it's the organization that gives them instructions on how to continue as dictated by the algorithm that we have designed, including risk stratification and MRI. And when he's considered to have a risk of significant cancers, then only he becomes a patient and should see the GP, his urologist, and so on, to avoid overdiagnosis and overtreatment, avoid what's ongoing today with too frequent checks and examinations, inappropriate age categories, as done in the opportunistic screening today. And why do you need it organized? Clearly, non-organized does not avoid overdiagnosis and overtreatment. There's a high cost and does not impact on mortality rates. But there is this obvious lack of public awareness. The public man care less about their health. So there is need for info, probably at sports events or public awareness, but also medical re-education. Our GPs, our primary care, still believe that a PSA above 3 will lead to a biopsy, while we have made an enormous progress to avoid overdiagnosis and overtreatment today. And we have been able to convince the Commission. The Commission has asked the SAPIA, Scientific Advice for Policy by European Academies, have asked to see what's the value of prostate cancer screening in an organized way. And they came to a conclusion that the scientific basis is strong, provided that the age criteria, 50 to 69, can be higher in some countries, and including MRI, will reduce opportunistic screening and will be able to reduce overdiagnosis and overtreatment. So they were convinced, the Commission. But conclusions and recommendations are not made by the Commission, they are made by the Council. And the Council is speaking with the different member states. And you look at the mortality rates from prostate cancer, how different they are in the different member states. This is the mean. And you see here's the Scandinavian countries, the Baltic states. Germany is somewhere over here. Belgium is even below. And you can understand that not all countries were in favor of agreeing to install screening programs population-based at that time. And there has been severe debates, and the Commission advising the Council to rewrite the recommendations on screening have weakened down this message, and they have come with the following recommendation. That was a compromise between the different countries, like I can tell you, Belgium and France being very much against introducing population-based screening. And the Council finally has said we need to do a stepwise approach, including piloting, reevaluate the feasibility, effectiveness, cost effectiveness, and so on. And very clearly, shortly after that, there has been new initiatives taken by the Commission. So to summarize, in 2018, there was the Europe's Beating Cancer Plan. 2021, we had our paper to the politicians. In 22, there was a SAPIA report really in favor of initiating prostate cancer screening, and the weakened down message from the EU Council in recommending exploration, the possibilities to screen prostate cancer. And in 2022, nearly immediately after that, the EU for Health has placed calls for proposals for innovative approaches for prostate cancer. And this is where the EAU has brought a consortium together, and where the PLCO initiative has been started and agreed upon by the European Commission. Also, the recommendation was outside PLCO to all EU member states to start piloting to see how, in the years to come, we should best do initiate population-based screening in the different countries. And that's the PLCO, and you see that EAU is leading this initiative, Erasmus Rotterdam being a very important partner in here with many others. We can go into detail in the next sessions that we will have in this webinar. We have 20 beneficiaries, we have a lot of participating partners, we need to give to the Commission the actual state of play, the psychological impact, the cost effectiveness. We have pilots in 5 different places, 2 in Spain, 1 in Ireland, 1 in Poland, and 1 in Lithuania. We will gather data from other pilots that are ongoing, and we have, for the time being, already more than 10 member states that want to collaborate with us. And we need to report back in 2026. This means that the Commission does not ask us to show that screening is effective. No, they want us to show that screening should be done, and the best way it should be done in the different member states. And I think I need to stop it here. PRAISE-U is the abbreviation for Prostate Cancer Awareness and Initiative for Screening, European Union. I believe that after 2026, we will have recommendations that will go into recommending population-based screening in the best possible way. Thank you so far. I will stop it here.
Thank you very much, Hein. That was an excellent overview. You're really motivated, and you're playing a huge role in Europe to bring this issue forward and to save men from the burden of prostate cancer, death, and metastasis. So happy to work with you on that. I think we enjoyed 3 excellent lectures from Sigrid, from Peter, and from Hein. If anyone in the audience has a question, please ask him in the Q&A so we can answer them now during this session or maybe later. Monique, do you have a question for any of the 3 speakers?
No, I don't have a question because I'm really highly involved in all these adventures, obviously. I just want to make a remark that I hope that the audience realize that we are in a very exciting period at the moment. So there are randomized trials and highly controlled trials ongoing still, which we can learn a lot from. But in the meantime, while this is ongoing, we have luckily now reached a point where we can look in daily clinical practice or in daily practice within the different member states, how it actually works out when we really implement a program into the clinical part, or let's say the medical environment of the different member states. So 2 ways actually, and I think both are equally exciting, and I'm really looking forward to discussing our next webinar really the results of not the randomized trials, but real life initiatives like PRAISE-U and part of EU Can Screen, which was not mentioned yet, but is another initiative where a lot of member states initiate programs, prostate cancer screening programs by the government, initiated by the government. So really looking forward to that. And I see 2 questions coming up, and we have 2 minutes left. So I see that Peter always already typing an answer. And there is another, let's see, a doctor from Nepal. Thank you for the presentations. We are having a study in our institute regarding PSA density and multiparametric MRI correlations, results in progress. Well, obviously, thank you for that. And we are really looking forward to that, because that is indeed, like Dr. van den Bergh already recalled in the question and answer, is the way to go. PSA density is a very strong risk stratification tool. There's another question there, and perhaps Roderick, you can say something about that. PCA3 as a screening tool. What do you think about that?
So the test has been available, of course, but in the meanwhile, MRI has become much more popular. I think we have an issue with costs here, with MRI, well, getting cheaper and providing actually better predictive value on the presence of significant prostate cancer. So within that whole pathway from PSA to a diagnosis, I think it's important to realize there's no perfect pathway. I think that diagnostic algorithm can differ per country, per region, per hospital even, dependent on costs, available resources. If you have many MRI capacity, please do MRI as often as possible. But if you have to risk stratify and save MRIs, please do a risk calculator first, or maybe add one of the urinary markers before that. But I think it's always a matter and balance in costs. burden on the patient, the number of visits, and the time that needs to be put in to come to a diagnosis. For now, I think on a large scale, there's not a big role for PCA3, but it may have in some regions who need further risk stratification before coming to that MRI and biopsy.
Thank you, Roderick. Thank you. Yeah, I think it's important to stress the difference between population-based screening and early detection within the clinical setting. There are totally different rules there. If you think about population-based screening, thinking of hundreds of thousands of men, I think you come to a total different ball game as that you think about your own clinic where you see, let's say, 100 men. So please keep that always in mind. If we talk about screening, we often talk about population-based programs.
So I would like to, almost conclude this session, but it reminds me of many cases I see in my daily practice. One is like the 60-year-old man with a PSA of 30 who never heard of the word PSA, which is unacceptable for me. And on the other hand, there's this 80-year-old guy who has his PSA done as just a checkup and at 3.1, and he gets an MRI every year, which is also, I think, unacceptable for me. So I hope that all our efforts on organized testing will solve these two extreme cases. And with that, I hope that you enjoyed our EuroWebinar on screening for prostate cancer. I would like to thank my co-moderator, Professor Roobol, Monique, of course, and all our presenters, Sigrid, Peter, and Hein, for this excellent collaboration. And I would like to remind our viewers that we have new webinars coming. The dates will be available soon on this same topic of screening for prostate cancer, but we will go into detail of other aspects of this important issue, of course. So thank you again. Enjoy your evening. And with that, I would like to conclude.
Okay. Bye-bye. Have a great evening. Thank you for listening.
Thank you all. It was a pleasure.